So let's start session. Live case number 3, Asan Medical Center, Korea, Imaging and Physiology and Calcification. I'm Jung-Sung Kim from Yonsei University Everance Hospital, and my co-chair is Seung-Jung Park from Asan Medical Center. We invited distinguished panelists Yoon-Seok Choi, Ankushi Gupta, William Gonta Hao, Jen Yu Liu, Yongbai Liu, Amit Sharma, Ken So, and Tepe Shugaya. So let's start from the live demonstration at first from the Asan Medical Center. Jungmin An is there? First case is Dogba.
Okay.
Yeah.
Okay.
Yeah.
Can you
please,
hear us?
Please start your case.
Okay. Thank you. Thank you, Professor Kim, and thank you, SJ Park, and the famous panelists. And we afternoon session, we also prepared a very interesting case, mainly focus on the left main and the severe complex calcified in ISR region. I'm DW Park and from Asan Medical Center. I'm gonna introduce our team and Jin Ho in our the senior fellow and Mr. Zhang is our senior technician. Okay, Jin Ho, can you introduce the patient background?
Yeah, thank you. I'm Jin-Ho Lee from Asan Medical Center. Let me start the brief case summary. A 54 years old male referred for chest pain. He had a history of STEMI with the PCI at RCA and circumflex artery 1 year ago at other hospital. A follow-up coronary angiogram at other hospital showed disease progression of left main. And he had a past medical history with the previous PCI and Ushiro stent 2.75 at distal RCA and Ushiro stent 3.0 at proximal circumflex artery. Next. In demographic characteristics, he had one risk factor with the smoking, and clinical presentation is stable angina with CCS functional class 2. Next. In electrocardiogram, basically sinus rhythm with no change of ST segment. Next. And in chest radiograph, there's no pulmonary edema and cardiomegaly. Next. And echocardiography showed the normal LV systolic function without wall motion. In 57, and the patient didn't get the image with the moving clip, so we directly show our coronary angiogram.
So, and briefly, the summarized patient, 54-year male, and 1 year ago, he received the RCA and substent owing to the STEMI, and the risk factor was minimal. Okay, this is a RCA, the right coronary view. You can see the big RCA, and the distal part is stent, is patent, and the mid RCA, we can see some mild disease. And next one. There's a big size RCA, and there is no significant stenosis remained in RCA region. And next. So, and this is the spiral view. You can see there is some, looks like a significant distal left main disease. And next one. So, and this is the area coral view. You can see the previous substent is implanted this 1 year ago, looks like a patent. You can see there was some, at least a moderate stenosis in the left main disease and trifurcation region, and the side branch angiographically looks okay. Next one. So, and this is the epicranial view you can see, and the left main, there was some stenosis angiographically at least 50%. And next one. So previous one. So, and this is the initial coronary angiography. So, any question or any comment for this patient in the angiographically at least 50% in left main disease, and the other previous stent is patent. A patient is a stable angina. It's just based on angiography. What is the panel and what is the audience plan? Previous one, I'm told you.
Is there any question for this case? Any comments from the panelists?
Any other evidence of ischemia, say non-invasive stress
Yeah,
test?
we didn't do and the non-invasive stress test and just stable angina symptom. Yes. Just by
Symptoms with,
angiographically. Yes. And we didn't check the treadmill test, the volume scan yet.
So do you usually do the kinds of strategy, or in this case is also much special? I mean,
So it's
especially for the most of cases with a stable angina, we did some non-invasive test before the angiography.
Usually, we are frequently do non-invasive testing, volume and treadmill test, but some significant disease like Lemmain and another very tight lesion, unstable patient, we don't do the stress test. So my question is based on angiography and most of the panel and moderator is fully agreed put the stand just based on angiography. How do you think?
Any comments?
Yeah. Yes.
I mean, maybe do an FFR and see, maybe, because since he's stable angina.
Maybe
FFR
just looking at the based on angiography, the previous syntax trial, previous pre-combat trial, we enrolled such like at least more than 50% the patient in Excel trial, as I mentioned before, and angiographically more than 70%, they define the significant Lemmain disease they enroll, and the 50 to 70%, they do some invasive FFR, or IVUS criteria, lumen area less than 6.0, they define the significant. Also, the patient should have documented ischemia by non-invasive test. That was in normal inclusion criteria for Excel trial. So my thinking is based on angiographically, I think less than 70%, just 50, 60%, something like that. And at this moment, we require something. We already checked the FFR, we already checked the IVUS, so we know answer. This, I propose, how do you think this panel? So any comment? So my simple question to the panel is how many panel think about FFR less than 0.8 for this region? How many audience? Yeah. Most of the audience think about FFR less than 0.8.
Can you raise your hands?
FFR low.
FFR less than 0.8.
Dr. Park, can we see the eleocaudal view?
Okay, we prepared everything. Okay, show eleocaudal view. This is spiral view.
Yes.
Another view. If you request, we're gonna show every view. Okay, this is the eleocaudal view. Okay. So the reason why, for complex, even simple Lemmain PCI is absolutely state-of-art PCI. We should very easily do FFR if required, easily do imaging, and the imaging-based and physiology-based Lemmain PCI would be, I think, some most updated Lemmain intervention in the contemporary PCI procedure. So we're gonna show us the answer.
Please go ahead.
So okay. The next one, we check the FFR. Lemmain FFR key step. Absolutely, some pull back the guiding caster is sometimes if you put the guiding caster that causes some impingement, the pressure drop, and fully pull back the guiding caster and the zeroing over here. And the next one here is we pass the LAD, and next one, and we check it up the FFR wire is passed well. Over here, we measure the FFR. At the FFR, we use the intravenous adenosine infusion, and then Uju shows the FFR value. The answer is 0.72. The baseline is a 0.9. Baseline was
92.
0.92 during the adenosine infusion, 0.72 in the obligatory drop, and then the pullback, the lemon ostium is going up to 1.0. Absolutely, by FFR, this patient has objective ischemia. FFR value was 0.72. So at this moment, we already evaluated the IBUS. Could you show us IBUS? Okay, yes. This is our criteria. Okay, we're gonna show the SOC. The previous SOC stand, could you show us our current? Yeah. Previous SOC stand is patent. GIR에서 넘어가야지. Okay, the stand was patent. Okay. Here, previous SOC stand is patent. Could you show SOC ostium? Okay, here is the SOC ostium. Ramus branch is coming. And the SOC ostium is lumen is okay. And we can see some eccentric plaque. However, lumen more than 7. So this is the distal and main. Also, could you show SOC ostium again? Here is the SOC ostium, is lumen is okay. We also measure the mid LAD to the left main IBUS. Could you show? 크리니알로 바꾸고 DIR로 해서. Okay. Play. Okay, we measured from the mid LAD to the distal left main. This is a mid LAD part, and the vessel size is 3.5. Here is the prox LAD, some narrowed part. We measured the lumen area is a 4.7. 4.7. Plaque seems like 60%, 50%, but this lumen is a 4.6. And then this is a much proximal part. And we can see some small septal branch, big septal branch. Okay, we can see the plaque. Okay, this is a prox LAD. Okay, the vessel size over here, prox LAD 4.0, is huge. This is the LAD ostium, the SOC. SOC is coming, the 9 o'clock. The SOC ostium is good. And the LAD ostium is spared, but the culprit over here, this is a distal left main. This is an isolated left main. The plaque was huge, and the vessel size is more than 4.5, and the plaque was extended. It's left main ostium. So I'm gonna summarize this patient. Is angiographically some ambiguous, and so patient symptoms is stable angina. We didn't do a non-invasive test, and we checked up the FFR. FFR is dropped down is 0.72. IBUS evaluations showed how much lumen area is mid LAD, prox LAD part is 4.7, and the distal left main is 4.2. It's very narrow, the huge plaque, and so I think this is absolutely the standard indication for left main PCI. So any until this moment, is there any comment or any question?
Actually, the number of minimum lumen area of the main shaft would be what? How much? How big? Minimum lumen area.
Okay.
Minimal
Okay, here.
lumen.
Minimal
Main,
lumen.
네.
It's the left main. Could you measure again? Over here? 4.8.
4.8.
거기서 한번 재봐. 치우고. Yeah.
Okay.
Here. Okay. Narrowest part. Okay. Here we measure again. Okay. So 3.7. 3.7. Yes, most
3.7,
narrowest
right?
part. Yes.
Okay, actually to treat or not treat, decision making really depending on the FFR concerns. However, particular these cases actually just we've done previously, isolated main disease we can clearly see that minimum lumen area value 3.7. We got a clear cutoff value 4.6, match with the positive
Yes.
FFR things. And so, in practical point of view, honestly, we don't need a two, support from physiology and imaging too, right? What do you think? And so if we're gonna do the IBUS, clearly we know that the minimum lumen area is very small, so
Yes.
we can treat them. Anyway, basically, it'll be different, support. However, particular for these cases, so we do just only IBUS for to treat or not treat decision, right?
Yeah. So is there any specific some criteria to apply only imaging?
Yes, so
Yeah, for the estimate.
as I mentioned, Professor S.J.
Yeah.
Park, in our previous data published approximately 10 years ago, and based on FFR criteria more than 0.8, our IBUS minimum lumen area is 4.6.
Yeah.
Another publication, Justice in the Circulation published, that was a 6.0, some difference. But
4.6.
our criteria is
Yeah,
4.6.
4.6.
Okay,
Yeah,
so
Yeah,
I've got a question. So
Justice
for
data is
Leming, should we just
5.9.
start with IVUS in the FFR then?
You mean,
And for Leming, I think it would make more sense, right? If we can use the MOA as a
all right,
criteria.
sometimes it's not, a visually significant disease or sharp areas. However, if there are downstream disease, we have to do FFR to treat
Okay.
or not treat concern for us. However, particular for these cases, are very much localized and clear. The minimum lumen area is smaller than 4.6. Actually, previously Justice data, the cutoff value 6 or something, right?
Yeah.
However,
Yes, right,
it's like
right,
too
right.
big, and so we use
Yeah.
the cutoff
Absolutely.
value 6 or millimeter scale is a negative predictability concern. More than 6, absolutely negative FFR.
Yeah,
However,
absolutely.
less
Yeah.
than 4.6 millimeter scale is a definitely positive FFR, right? That is
Absolutely.
in the-
Yeah,
Yes.
I think that is a very important point to using
Yeah, absolutely. The
intravascular
reason
imaging.
why the XL is adapted to a criteria, lumen area is more than 6.0 or FFR less than 0.8. Yeah, they
So
define
two important some question is one is what is your prepared strategy based on the imaging, because you already checked the LAD and circumflex and left main.
Yes, yes.
And the other thing is I think
Yes.
it's also important to cover the left main ostium or not, because it's not clear in the
Yes.
intravascular imaging.
Yeah. So, and the FFR was used to treat or not treat. There was a decision-making process, and we decide to treat. So based on IBUS, we decided to regional length and the vessel size. And based on the IBUS and the proximity lumen is a 4.7. It's just a little bit alone. We're gonna just the short stand based on IBUS, and we put the 4.0, and we are trying to fully cover the lemon ostium. So, and we are due to the time limit, we're gonna proceed our procedure, and we select Synergy Megatron 4.0, and as everybody know, where is one of the advantages of Synergy Megatron from Boston Scientific is the radial force, most strongest among the available drug eluting stent. This is available 3.5. Using 3.5, you can inflate the 6.0, also diverse size 3.0, 4.0, up to 5.0. Also, visibility is good, and the radial pulse is the most strongest. So, I think the Megatron platform is one of a good option for treat the leg main disease. Okay, test. Okay, test. Aerial cranial view. test. 좀 절로 조금만 더 돌려볼까? 그렇지.
Another point I would
We
make
try
here is
to-
not much of calcification. You didn't see much calcium there.
오케이, 테스트. 조금 더 여기 제일 잘 보이는 다른 뷰 더 잘 보이는 데가 있나? 테스트. 여기 제일 잘 보이는 것 같습니다.
Further,
조금만 더
stand out.
나올게요.
Great.
오케이. 여기 테스트.
Perfect. A little bit further, 1.5 millimeter.
한번 찍어볼게요. 천천히. 자. 이제. Okay, we're gonna check another view. 오케이, 테스트. 조금 더 나와야 되겠다.
Great. Pull the stent out
Okay,
a little
test.
bit further. A little bit further, maybe.
오케이, 테스트.
Proximal lesion not yet covered by.
저 뷰는 어디지?
아래 우편을
Okay, we can check it up the several view.
약간 거의 AP처럼 가겠네.
Okay, 테스트.
테스트,
이게 뷰가 다 가리네. 이 정도.
테스트,
테스트. 잠깐만요. 혈압 괜찮지? 네. 오케이, 테스트.
테스트.
자, 이거 괜찮아 보인다. 샬로 에러로 파이널. 페이션 디스크 테스트. 가자고.
11 가겠습니다.
11.
11,
오케이, 12.
12,
오케이, 디플릿. 오케이.
What stent do
I
you
think
use? What kind of
this
stent?
is the Megatron. Yeah, Synergy Megatron.
Uh-huh.
Yeah. Okay, NC1 high pressure. Synergy Megatron is the thickness is 89, slightly thicker, but radial force is the most strongest among the available drug-eluting stent. Is the Megatron was designed to treat the big vessel like left main, and the visibility is good.
앞담량 10mm입니다.
I have no important conflict of interest with the Boston Scientific. Okay, so this is a 4.0. Okay, 네. 오케이, 잠깐만. Good, go. 12,
12 가겠습니다.
14,
14,
16.
16,
Okay, deplete.
What size balloon do you apply?
4.0.
4.0.
NC balloon.
Yeah.
자, 20,
20 가겠습니다.
20,
20,
22.
22,
Okay, deplete. We have know the vessel size exactly based on IBUS. Okay, 22, hanging out, 24, 26.
6,
Final
Okay,
final
deplete.
balloon diameter is in the 24 atmosphere. What could it
24
be?
is how much? 4.3. Okay, go.
4.3.
20,
한번더
yes.
하겠습니다.
22,
22,
24,
4,
Pressure 4.3.
26.
26,
Okay, deplete. Okay, and then we will check and the IBUS over here. Okay, angel ready?
네.
준비됐죠? 오케이. 자, persia. Good.
Great.
And the coral view.
가로.
잠깐 LA로 들어가는데 좀
이렇게. 테스트.
테스트.
오케이, angel ready?
레디.
Okay.
Great.
Good. And the spider. And then we're gonna check the IBUS. It's a discussion point, many discussion point. Procedure is simple. That is our, catchphrase. Complex PCI make it simple.
This is perfect case
Okay.
for the complex
Yeah.
PCI. Make it simple.
Yeah, we're gonna check it up the IBUS quickly.
Basically not complex lesion, right?
So, and such like a region, and this case is a very good case to discuss IBUS as well as imaging. Some not tight. Okay, over here. Okay, 자 여기서 봐. So we're gonna put the plant to the proximate part over here. This is our target part. Good. Is there is no inner position expanded well. Lumen is sufficiently expanded. We are using the 4.0 non-compliant. We inflated up to 26. Circle all-stream is coming. It's good. Widely open. This is the distal left main. Is a target region. The huge plaque. Lumen area just 3.5, and we are fully expanded. There's a
Perfect.
hanging out, and 3 and 4 is good. It's, I think, fully covered the left main osteo. So that was our final result. In the many discussion, the short PCI.
Okay.
Any comment or question?
Perfect result. Any comment, Evan?
Yeah. Any comment?
I think initially when we saw the IVUS run, we could see there was some calcification there at the distal left main, which is an eccentric calcium there. So I wanted to know whether can we pre-dilate this with maybe a cutting balloon or something, as in the all left mains. Do we use cutting balloons or any sort of plaque modification at the distal left main?
So it's question about this pre-dilation,
Yes.
debulking.
Yeah, so
or other,
usually the IVUS evaluation at the very ring calcium, very sick calcium, we sometimes do the cutting balloon or scoring balloon. So although IVL, intravenous lithotripsy, was not available, we discussed the international faculty in the yesterday. Intravenous lithotripsy is very, very useful. Using just the 4 ATM, 5 ATM is a finely crack down the deep calcium or ring calcium, but it's just one problem: is the price is high. I think even though left main disease and the big size vessel, calcium was too much severe. Intravenous lithotripsy is using radio would be the next the good option for crack down is severe calcium, also region preparation. Okay, also angio. Final. It's good. Good.
Good.
And then spider view, and then we're gonna finish. Okay.
준비됐나?
Okay, good. So, and
Perfect.
yeah,
All
this
right.
is our final result.
Dr. Bach
Okay,
is really
thank you.
great cases, very much educational. I summarize, look at that. This is, by definition, wise, high risk complex angioplasty by angiographic findings, right? Main bifurcation, and there are some disease, proxerate, circumflexerate, ostium, something like that. However, if you look at the obvious findings, you got some concept, insight about what the plaque distribution would be, something like that. The candidate is very, simple cases, just the stent crossovers. We don't, worry about it. That is, purpose of our, make it simple, for the complex region subset. All right, thank you.
Thank
You want to
you.
move
Thank you.
another
Nicely
room?
done.
Thank you.
Excellent.
Okay, is there any? Dr. Han,
Yeah.
can you hear me?
Good afternoon, Dr. Park. Yes, I can hear you. Can you hear me?
All
Yeah,
right.
yeah,
Can
we
you hear me?
Yeah, we can hear you. Yeah, clearly. Yeah. Go ahead.
Okay. So I prepared my second case. Second case, it looks very complex. My senior
I
fellow
don't
will
believe in
introduce
complex, right?
my senior fellow will introduce the patient history and angiogram.
Yes, thank you. Let me start the presentation of this patient. This patient is 74 years old female, and she was diagnosed stroke about 1 month ago. During the management for stroke in an outside hospital, coronary artery was also evaluated because of intermittent resting chest pain. After she was diagnosed left main and 3 vessel disease, she was referred for management. 1 week ago, she underwent PCI at proximal middle RCA with Giant Sierra 3.25 with 33 millimeters of length. Next. The risk factor of this patient is hypertension and hyperlipidemia and stroke. And the clinical presentation is stable angina. Next. Electrocardiogram showed sinus bradycardia. Next. And there is no abnormalities on chest X-ray. Next. Echocardiography showed normal LV function without regional wall motion abnormality. Next. The right coronary angiogram showed the patent stent previously inserted at proximal middle RCA. And left coronary angiogram showed diffuse long lesion at left circumflex artery and left main to middle left anterior descending artery. And The tightest stenosis at diagonal os. Next. The target region of this patient is left main bifurcation and diagonal bifurcation. We prepare the IBUS for intracoronary device. Thank you.
Do you have any comment on question on patient angiogram and patient history?
All right.
I think definitely the indication for bypass surgery, but the patient diffuse and past history of 1 month ago had a stroke, so she want to have a PCI instead of bypass surgery.
You have already correct the right coronary artery, right?
Yeah, right.
Okay. Very diffuse, really complex disease. Very good candidate for surgery, right? So, any other opinion from the panel?
Is there any comment?
I think there's a diffuse disease. If we can see the entire left main to LAD, and I'm a bit concerned about the flow in the LAD. It's not TIMI3, it's slightly lesser than that. So that may be a little concerning here. You know, I would definitely treat both the branches. Yes.
Okay, definitely,
Next.
long diffuse disease, distal lung is quite well preserved, a good candidate for surgery. However, we have another choice. And so, what would you do there, Dr.
Yes, so far it's next. So actually, after insert wire to the LAD, the no flow to the LAD, so I ballooned the LAD first, and so the next I implanted one stent to the circumflex. Actually, there is two bifurcation: left main bifurcation, high diagonal bifurcation, and another big diagonal branch bifurcation is already ready.
Ready?
Can you see some collateral fall? But initially, big diagonal branch already occluded. So that I think that diagonal branch cannot be graftable when you do the bypass surgery. So anyway, just the information.
All right, emotionally quite comfortable, right? All style
But there is only one.
included. And
Yeah. So there is actually there is a high diagonal branch, but the supplying myocardium is not so big. I just focus on the diffuse LAD and circumflex disease and left main bifurcation. So ready?
Ready?
So I implanted one stent to the distal circumflex. Another stent, please give me another stent, 28.
you want to
After
make?
circumflex stent.
Do you want to do crossings
Yes,
with
yes,
the
right.
bifurcation? It's a long
Yes,
stent.
right.
How would you find? Is there any cut-off lengths in terms of good clinical outcomes? Dr. Han, could you tell us that? And how
Yeah, for
long
the- what is-
stent would be good
Yeah.
in the real practice?
Yes, actually, we need second generation, third generation DS data, but we have the first generation cipher-text data based on the IBUS findings up to the 38 millimeters, one stent length, or longest one stent length. The instant retention rate during the follow-up is very low compared with the more than 40 millimeters. So we don't care the implant stent length up to 40 millimeter. So I think even in addition, we have another the data about the full metal jacket. Full metal jacket means the longer than 60 millimeter overlapping stent implantation. So we did a 7 years follow-up. The event rate is annually only 2%. So I think the contemporary DS, the second and third generation DS, if we do the good position expansion based on the IBUS guided PCI, even though long stent implantation, patient long-term outcome should be good, I think.
So, right, roughly, can you say the cutoff is a 60 something? 60?
Yeah, I believe so. I believe so. 60.
In any, stent, personally, I think is lumen diameter is important. If the vessel is big enough, more than 2.5 something, so why not? We're going to do the 60, 80, avoid the malposition and the good effective stent area would be good for the long-term outcome. So recently, using the second, third generation drug stent, we're going to use almost 60, 80 in
Yeah.
some cases.
I think I fully agree, but I think imaging guidance is very important to expand the fully stent
Long region
optimally.
surgery, right?
Yeah. Also, the other question is, do you check the IVUS, because there are lots of significant amount of calcification in the angiography. So I think
Yes,
if you achieve the optimal stent expansion, I think this is also important point.
Rather than
yes,
length,
we
right,
already, for LAD is very tough, so we evaluate the circumflex first. Could you show us the circumflex IVUS finding?
컴플렉스 아이비스 보여드릴까요?
네. Here is the distal reference.
2.5.
언론입니다. LAD.
And actually more than 2.5, 2.75. Huge plaque. Vessel size is not so small. At least 3.5. Actually diffuse disease.
So you prepared another balloon for the LAD, Sunshine?
Yes, right.
Right.
Now I'm preparing another balloon for LAD. So treating circumflex and then it makes, I think, make my procedure simple.
Great.
Anyway, test please.
테스트.
You have to check the
Okay.
LAD floors.
Test.
테스트.
All right, slow floors.
Test one more.
more.
Okay. Inflation.
인플레이션. 12. 12. 3.5. 12.
Certified.
Yes,
Big
depletion.
enough.
Yeah. This is a circumflex.
Yes.
10,
10.
16.
16.
Depletion.
인플레이션.
Oh, I'm very nervous because of LAD flow. I removed everything for wire. 6,
6.
8, 10,
10.
12,
12.
14.
14.
Depletion.
인플레이션.
14,
14.
16, 18, 20.
20.
Depletion.
인플레이션.
Can you see the crusted area of circumflex?
Okay, well then,
Yeah.
all right. Why don't you do the
24.
balloon inflation LAD
24.
further,
Yeah.
24.
proximal,
Inflation.
mid portion to
Yeah. This is the used one, so I think we need a smaller balloon. This is a 2.5 compliant balloon, please. Ready?
Ready.
Okay. So we make a good flow to the circumflex. I like to go to the LAD. 네.
Dr. Han,
Yes.
which is the best strategy to fix to the distal or middle LAD and then put another stent to put proximal circumflex? Because I think even though you crush the stent,
Yeah.
sometimes it's not so easy to deliver some device to the distal LAD.
Yeah, I fully. That's why I focus on the high pressure to the left main. So yeah, I fully agree with your opinion. 10. But in case of very diffuse disease, so sometimes the distal, even though the place distal LAD stenting makes some no reflow or something like that. So I want to just correct the large circumflex first.
what size? What size balloon?
T25.
25 non-compliant.
Yes. Compliant balloon deflation.
Compliant.
Yeah.
So you want to
14.
make a flow first. 25 compliant.
Deflation. Yes. Yes. Then I like to, if possible, I like to see the IBUS. Ready?
Ready.
So, Dr. Park, so for your case like this,
Okay.
now, do you consider to use DEB for distal vessel and then the stent for the proximal vessel? So by doing so, we can minimize the length of the stent.
DB, you mean?
Yeah. Or you don't believe in DEB, you think stent is better?
There is already
Cranial.
dissection.
I'm talking about like the second phase. Right? Let's just talk about the length of the stent need to be shorter than 60 millimeter.
I was trying you want to learn something is that maybe the region itself a little bit, calcified the region, something like that. 2.5 compliant balloon actually, can make a big dissection in the mid portion, so it's not too much a soft one, right? We have to do the stent for that.
Okay.
Alright, 2.
Yeah.
Why don't you do the nitroglycerin 2, right? Getting
Yeah.
bigger.
Right. 네. 나이트로 좀 주세요. 저 조금 이따 줍시다.
2.5. 2.5 something, right?
위에서 내려온 것 같아요.
Yeah. Right.
5 distal. 2.5 more than that, and 3 or something.
The region starting here, very centric calcification, 2.5, I think. I think that I implanted 2.5 here, and then based on the IBUS finding after nitroglycerin, I selected a bigger high pressure balloon.
Focal calcium, some maybe a dissection here, 2 o'clock. All right, 1 o'clock. Encircling calcium maybe, fractured by a 2.5 balloon here. Very much calcified region, right?
Yeah. Right.
But
In this
even though-
situation,
yeah.
the fully region modification is very important.
Yeah, I fully agree. Yeah. So I think
So,
in
but I believe
this,
Oh,
I
where
believe
was
that
it?
if I can insert
Encircling calcium.
left main,
You may need an NC balloon, high pressure inflation.
yeah, right.
For the
Yeah.
stent procedure, right?
Here is a very high, just a proximal ostium of LAD. Okay, here is, you can see the crushed circumflex stent. Here is the left main. Some dissection in the left main.
All right. However, it's okay. You can cross that out. Calcium.
Yeah,
Not your calcium.
we have to cover the very austere part of left main. So could you give me the 3O high pressure balloon?
Yeah.
We already knew that the vessel diameters, below the curve mid LAD, vessel diameter is only 2.5, so I cannot apply the high pressure balloon.
나이트 줄까요?
Yeah, please, nitro, please. But the proximal LAD vessel diameter is definitely more than
나이트 들어갔습니다.
3.0.
Yeah.
So to break the further and for the stent expansion, so I like to aggressive the region pre-modification for proximal LAD site. 10.
10.
Deflation. 16.
16,
18, 20.
18, 20.
We have to check the full expansion of a balloon.
3O.
Deflation.
3O non-compliant.
Yeah, 3O.
All right.
20. Yeah.
You have to take
20.
care of a
20.
little bit far distal LAD though. LAD 2.
Yeah. 25.
25.
20. Deflation. 25. Deflation.
잠시만.
Trio and C balloon.
Yeah. So just take a moment, please. Patient blood pressure is a little bit low, so I think because of nitro, so I like to take some time. 볼륨 좀 더 주세요.
3mm.
Ready?
Ready.
Good.
Oh, flow is not bad, so far good. So
A little bit worried about, mid portion of LAD, the dissected area. There may be some,
2.5 high
compound,
pressure balloon, please.
high calcium localized
Yeah.
focal one, and so you have to, modify.
2.5 high pressure balloon, please.
I think this case is a little bit complex, right?
Yeah.
Right.
More complex than
Very,
previous one.
right, a little bit.
But he demonstrated the crush very nicely. What I have seen most of the times is because if the crush is not adequate, the recrossing becomes a nightmare at times. I keep telling my fellows that the crush has to be really good, and it's nicely showed, almost twice and thrice, so that it allows his wire to recross
10.
later on.
12, 30, 14.
14.
So here the vessel size is 2.5, so I selected 2.5 high pressure balloon, pen. Fortunately, the patient blood pressure is going up. I think it is due to the nitro. Some under expanded balloon 10, 12,
10.
14, 16.
Now fully expanded. So
네,
far.
deflation. Yeah, but considering the risk because the vessel size is only 22.5, so I don't apply to more. After the implantation, I consider the high pressure ballooning. So
Later.
2.5, anyway, 2.5,
Doctor,
2.5, 38.
Doctor, do you have
Yeah.
time? If you have time and patient stable, I think it's possible. It is very educational to show the IVUS, just a short segment of the calcified lesion.
I was again.
Yeah,
IVUS, please.
yeah,
Yeah.
just short segment. Yeah, calcium is a crack or not.
Yeah.
Well modified or
Alright.
not. Yeah,
Let's
this is
see
a very
that.
important point.
Okay. Patient blood pressure is the more stabilized, so we have time for IVUS evaluation. Okay, here. Yeah. This is the mid-LAD normal looking area. Small.
Nitroglycerin,
I like to implant
did you give?
if I gave the nitro already.
Two something, right? T-cell.
2.5. Yeah. Yeah, right. 2.5.
Okay. Clear. Oh,
Yeah.
some
Here,
dissections.
here is some
Tissue.
dissection.
All right. Just below the focal calcium, localized calcium, yeah.
Yeah, right.
Vessel size was
Yeah,
big one,
correct.
right? 3 or more than that.
Yeah. Proximal LAD vessel size is not so small. What is the overall lesion length? From the mid-LAD to
Alright.
the left main?
Breakdown, cracking the calcium, inner calcium.
Over
12
Total length.
o'clock, 6 o'clock, right? NC balloon walks.
Excuse me, I missed. Yeah, I think so. In most cases, if the IVUS passing through, I believe that the high pressure balloon dilatation can break the most calcified
6 o'clock, 11
most
o'clock.
calcification.
Anyway, crack down. Vessel size was very big one, so 3 or
Okay.
more than that. Is this main?
Yeah, main. Yeah.
Yes, main.
So where did you do that?
Yeah, I implanted the stent first. Yeah. LAD
Stent.
stenting.
Anyway,
Could you give me the 2.5?
you may need at least 2 stent, right?
Yeah, two
스팔
cent.
드릴까요? 아니면
And so for the
Yeah,
distal
right.
part, what size,
Yeah,
what length?
2.5.
2.5.
One
랭스가 어떻게
length
돼요?
38mm 일단
38.
38.
Overall lesion length is 62 based on the IVUS.
38. You have to use another big, okay, stand for the cross shape, for the lemania, right? Okay, good.
dimension
Test.
테스트.
Okay. 10.
9 and 2.63
10.
2.5. 2.5.
2.5 deflation.
그렇죠?
Okay.
16.
2.83
16.
Deflation.
One more balloon, yeah?
38입니다.
Test.
테스트.
Test.
테스트.
Okay. 32, 33.
예, 33.
Next.
8이고.
3.5, 33.
예.
33. 38.
Yeah. Yeah. All age we use the A-French guiding catheter and with the side hole, particularly for complex left main PCI.
Okay.
Test.
테스트.
Okay. Overlap.
오버랩 테스트입니다.
I check the overlap.
Ready?
Test.
It's good. Too much. Just
Test.
a little bit. Pull the stent out. 0.5 millimeter something, right? Good. Okay.
Test.
Perfect overlapping.
Okay. Yeah. Test. Okay. Go.
12.
10.
10.
and 3.47.
10.
Deflation.
그렇죠?
$16,
3.7.
16.
18,
18.
3.77.
deflation. Could you give me the 4O high pressure balloon?
4.0.
What is the left main vessel size?
4.0입니다.
Okay, 4O high pressure.
Oh, you want to make a high pressure part and wire again.
Yeah, for
Circumflex.
예.
10mm 드릴까요? 15mm 드릴까요? 15mm입니다. 선생님 앞에 빼주세요.
I believe that the LAD optimization is more important than the side branch treatment. So I made a good opposition for the left main side because the left main stenting is already protruded to the aorta. So I want to make a good opposition and expansion for left main side. 20.
12고 4.0입니다.
20.
Deflation.
NC balloon, right? 4.
Yes.
Okay.
4 NC. 20.
네. 4.2.
20.
24.
Perfect.
24.
4.25.
Deflation. So I like to see the IBUS first before high pressure balloon because based on the IBUS finding, I like to select the high pressure balloon size.
So you mean is this a
I
strategy for
believe-
the pot or not? Because the balloon
Yeah, this is the
location.
kind of part, but I don't like
Yeah,
to say.
because the balloon
Actually, I
location is
don't
not
like to say.
the position for the pot. Just a proximal LAD
Yes,
and left main.
My understanding about PAD is the one step for the angiography guided PCI. So if you do the IBUS guidance, we don't adhere to the PAD. We don't adhere to the PAD, stick to the PAD. Based on the IBUS findings, you can select freely. You can select the balloon size and ballooning location. So anyway, this is the distal stand.
Okay. Distal end, landing is good.
Okay.
2, 5.
Landing is good.
Right.
2, 5, yes.
2, 5, maybe.
I
Standing
didn't
area,
apply high
standing area is
pressure
not
here.
less than 5, however, it's quite good. Pressure size-wise, relatively small one, and so stand-up position is good. All right, here, still eccentric.
Here, yeah.
All right, under expansion.
So we need a high pressure.
All right.
Yeah.
Very high pressure, right? 2.75
Yeah.
something.
여기는 다 늘어날 때 늘어났다.
Okay.
All right. Exactly, we expected, the focal calcium area is not fully expanded.
Okay. Here we cannot. Yeah, we can apply the at least 3.5. Here is a prox LAD.
Good. 3O, stent diameters, maybe 6, 7 millimeter square. Quite enough. Still prox LAD one? The main?
Here is a very
Not
yeah.
3
Very
o'clock,
prox or LAD. Circumflex coming from the
4,
5 o'clock.
5 o'clock.
Here is the left main. I applied the very high pressure using the 4O up to 24, 25.
Exactly 4O.
Final
Right?
balloon size was 4.2. Yeah.
You mentioned about the cutoff, it's 11 millimeter scale, right?
Yes, 11.
Perfect position. Okay, Dr. An, thank you for your great
Yeah.
cases, and so we're a little bit behind the schedule. And the next two talk.
Okay.
After that, so you explained what you've done, finally, right?
Okay.
Okay.
Thank you.
We will
See you
be
soon.
back. Okay, next we're gonna have some lectures. Do Yung-gang,
Yes.
my approach to intracoronary imaging, the master skill secret. Dr. Gang, please.
Thank you. I'm Dr. Yoon-gang from Asan Medical Center. Today I will talk about my approach to intracoronary imaging. I believe that there are two fundamental questions for interventional cardiologists when performing a PCI. First would be this lesion significant? That means does this region make ischemia and should it be treated? Second, has the PCI been optimized? And for the first question, physiology, FFR, IFR can answer. And for the second question, intracoronary imaging guides. Angiography is a luminography, therefore, angiographic imaging can be limited in some eccentric region and it cannot visualize the vessel. Intracoronary imaging visualizes the real vessel. How intravascular imaging changed the procedure? In ADEPT-DS study, the procedural changes after IVUS was done in 74% with the larger size of the stent or balloon and higher pressure balloon and longer stent and additional post-dilation. IVUS improved clinical outcomes in large RCTs. In IVUS XPL of the Dr. Hong, in long region, IVUS use decreased MACE about a half in the large size randomized trial. In ultimate trial with the Sharing Chen, that with the all-comer PCI, target vessel failure also became a half in IVUS guided PCI. Also, it improved clinical outcomes in CTO PCI. Dr. Byung Kim, they published the CTO PCI trial that made the clinical outcome improvement with the IVUS guidance for the CTO PCI. And also, IVUS use was associated with a better 10-year more outcomes after left main PCI in main compare registry. And there are so many meta-analyses, and updated meta-analysis of the 10 RCTs also showed the IVUS use was associated with the cardiovascular mortality, myocardial infarction, target lesion revascularization, and stent thrombosis. And the recent guideline recommends IVUS as a 2A recommendation for the left main or complex coronary artery stenting, and OCT as a reasonable alternative to IVUS. And IVUS or OCT was also recommended for the stent failure. Then what would be the role of intravascular imaging for PCI guidance? It is to optimize acute stent result. It can be used for the guide wiring in the complex bifurcation or CTO regions, and also we can assess the plaque characteristics and perform adequate pre-modification. And can confirm the result of the plaque modification in calcified region, just like the previous live cases. And also you can check the calcium angle, thickness, length, and then to select the atherectomy or other debulking devices. And also you can select the clean landing zone. That means that we can make an appropriate stent length and with a larger stent. We can assess the optimal landing zone with the intravascular imaging like this. And the best cutoff of the HG stenosis in our center's data was the plaque burden less than 55%. If you can select the landing zone with a lesser plaque burden, the clinical outcome will be better. And also effective stent area more than 5 square millimeter was associated with a lower TLR rate. And this is a famous figure with the stent area in left main bifurcation PCI. The message is the bigger, the better. And the intravascular imaging can make it. And you can select the large size non-compliant balloon for post-dilation. It's very important. In our IRIS-DS registry, we selected more than 9,000 patients with a single complex coronary lesions like left main bifurcation, diffuse region, severe calcified region, instant stenosis, and check the primary outcome of the cardiac death, target vessel MI, and TVR. And we call the image-guided PCI as an imaging-guided PSP, IPSP, with a predilation and stent sizing by IVUS, and surveillance and post-dilation with a larger NC balloon. An imaging-guided group showed higher stent number, longer stent length, bigger stent diameter, and bigger final balloon size compared to angiography group. And the primary outcome was much better, significantly better in IPSP group, even after multivariable analysis and aggressive matching method. And the post-dilation was the most significant event predictor among 3 components of the IPSP. And post-dilation balloon size was even larger, with IVUS group, about 0.3 millimeter larger balloon was used in IVUS users group. What does it mean? with intravascular imaging, I can implant bigger stent with a higher pressure post-dilation safely because we know the vessel size. And that kind of small details make a big difference in long-term clinical outcome. The similar result was also shown in IVUS XPN and Ultimate patient-level pooled analysis by Dr. Myung-Ki Hong. They merged two databases with the longer stent PCI group from two RCT, and when applied various definitions of the stent optimization, about half of the patient could not meet the optimal stent expansion criteria. And those kind of the patient without optimal stent expansion showed worse clinical outcome compared to optimal stent expansion patient. And the study also showed that when we perform the post-dilation with IVUS, the minimal lumen area was significantly larger than angio-guided group. And those kind of patients with the IVUS-guided post-dilation showed significantly better clinical outcome. That means that when angio-guided post-dilation, we can only see the lumen. And usually we select the stent to reference vessel diameter ratio between 1.0. But if we use the IVUS, we can select bigger balloon with a stent to reference vessel diameter ratio, usually with the 1.1 to 1.3. And bigger balloon, bigger stent make a bigger lumen area that makes better clinical outcome. This is a case from the Myung-Ki Hong that the giant stent and performed the 3.5 NC and the perforation happened. The possibility of the coronary artery perforation during the aggressive PCI can happen when we do it without use of IVUS. The last role of the intravascular imaging would be the post-stenting surveillance for stent opposition, expansion, and edge problem. You can clearly visualize the result of the stenting and can find the edge-related problems. So this is my conclusion. What is the use of the intravascular imaging? The bigger by the use of the imaging would be the better. And is there any muscle secret skill? No, there are no secret skill. I recommend just do intravascular imaging for complex PCI and just do your best to achieve optimal imaging criteria. Thank you for your attention.
Great. Next up. Okay, as our next lectures, Dr. Antonio Colombo, should we prepare the recording? Okay.
Is Antonio Colombo presenting how to treat heavily calcified lesions, PCI. I have no conflicts to disclose regarding this presentation. In the AVIO trial published in the American Heart Journal 2013, first author Alaide Chieffo, the investigators were not able to achieve optimal stent expansion in 40% of the lesion. The technology to treat calcified and fibrotic lesions were not present or not fully utilized. These highlight the fact that even with IVUS guidance, we may not achieve a good result if we don't act properly. What is the approach to calcified lesion presently? The approach takes the benefit of high-pressure balloon and very high-pressure balloons, rotablator, orbital atherectomy, angioscalp, cutting balloon inflated at 20 atmosphere or more, shockwave balloon or lithotripsy, and laser with contrast injection. Let's go to the first technology, very minimalistic, very high-pressure balloon. The OPN balloon is a double-layer balloon which is able to withstand up to 36-40 atmosphere. Here you see a stent underexpanded because of fibrotic lesion in the proximal right coronary artery, 3.6 cross-sectional area. Following inflation at 40 atmospheres, we can reach a 7.7. This technology is powerful but not always effective. If the calcium is very thick, or you have a fibrotic, which is not responsive to high pressure, the technology may fail. Rotablation and non-compliant balloon with cutting balloon when needed is the other technology frequently utilized. This is an example of rotablator 175 in a calcific lesion of the LAD. After rotablation, high pressure balloon is inflated with a partial cracking, but not complete cracking of the calcium. You see that in the yellow area of cracking, that's the reason why we added another technology, which is a cutting balloon inflated at 26 atmospheres. Remember that when you inflate the cutting balloon at such a high pressure, the device is compliant, and you need to undersize the cutting balloon, otherwise you may have complications such as vessel rupture. After cutting balloon, you see additional cracks in the calcium, and therefore the lesion is properly prepared. So combination technology is important. The new arrival is a shockwave balloon. A shockwave balloon, also called lithotripsy. You see a lesion in the mid-LAD with OCT demonstrating thicker calcium. The lesion is prepared with shockwave, 4 atmospheres, 8 sessions. You can also inflate at 6 atmospheres, but most of the time 4 atmospheres is the way to go. After shockwave treatment, we almost always proceed with a high pressure balloon. The OCT shows some cracks, but not completely. In B, there is some cracks, but we like to have better lesion preparation, and that's the reason why we add high pressure balloons up to 24 atmospheres. You see full balloon inflation now, and at this point we proceed with stent implantation and post-dilatation. Here is a good result with excellent lumen achievement. And you see the final symmetry, which is obtained after combination of shockwave and very high pressure balloon. Another example in a left main with a bifurcation lesion. This left main is treated with 2 shock waves on the circumflex and on the LAD. Here you see left main towards the LAD and left main towards the circumflex. 8 runs for each vessels. And here you see the final result. Please notice the large lumen on the circumflex, which is really the way to limit restenosis in this vessel. They disrupt CAD 1-year outcome in 384 patients, report a low MACE rate, considering complexity of the lesion of 13.8, 1.1 cardiac death, MI 10.5, stent thrombosis 1.1, and ischemia-driven target lesion revascularization of 6%. Shockwave is a very effective technology, but when you have a focal calcium, may not work. So in this situation, it's difficult to find a solution. Maybe orbital atherectomy sometimes works, but this remains a problem not always easy to be solved. To conclude, laser with contrast injection is mainly utilized for under-expanded stent. We use excimer laser 0.9, a small catheter with 80 millijoules, 80 hertz, maximum fluency, maximum energy, 1 or 2 passes localized to the stent. And on the right side, you see how nicely the lumen improves. So to conclude, rotablator, orbital arterectomy, cutting or angiosculpt inflated at high pressure with IVUS guidance for optimal sizing. Make sure not to oversize. OPN, very high pressure dedicated balloon up to 40 atmosphere, shock wave of lithoplasty or lithotripsy, laser with contrast injection, mainly for under-expanded stent. And remember that one approach may not be sufficient and be liberal to use more than one when needed. Thank you for your attention.
Sure, and let's move on to the case.
All right, you're gonna move on the Caleb. Move back. Can you hear me, Dr. Han?
Yes, I can hear you.
All right, great.
Yes.
We have very limited times, and so another two cases would be 20 minutes, 20 minutes. You have to make a complex to simple, right? All right, would you explain that one, last one?
I just insert the wire.
Still you are doing?
So now yeah, I'm doing.
So wiring.
So
and
yes, I wired to the circumflex, but wire kinked, so I like to rewire it again. So actually, frankly, I don't care proximal part, distal part. If wire go inside, I'm very happy.
Okay, that's great.
Yeah.
So,
So
was
could
you
you
gonna
give me the
do?
tool?
Was you gonna do kissing balloon inflation?
Yes.
Okay, all
I
right.
didn't do high pressure.
High pressure.
2.0.
Okay, we're gonna move.
Yeah.
Dr. Han,
Two-
so we have limited time, so
Yeah.
we're gonna show some the other cases,
Okay.
and we'll be back, right? Okay,
Okay.
Dr. Gang, can you hear
Okay.
me?
Dr. Kang, can you hear me?
Another.
4.0 대 3.5 될까요?
3.5.
3.5.
3.5.
In this, Dr. Han, in this,
I think
Yeah.
yes, I think some the problem in the connection, so that I have to keep going.
oh yeah, that's right, no problem.
My-
So
my
you
press-
usually recommend
yeah,
to the
yeah.
distal wiring. So
Actually,
But
the
you don't
crush
care
technique,
about
the
that, yeah.
decay crush group,
yeah,
decay crush group recommended proximal wiring, but
Okay,
actually I don't care.
yeah.
continue.
6, 10, side branch 10,
오케이, 좋아요.
What size balloon circumflex force?
2O,
2.
10.
10, deflation,
여기
LAD 6,
It's kind of
6,
anchoring,
10.
right?
circumflex 10,
Anchoring.
2.0 10.
deflation,
deflation.
LAD는 가만히 있고.
Great. All right.
okay, 10,
That's the point, right?
LAD deflation,
Proximal
2.0
part
10.
inflated balloon. This is
12,
compliant
13,
balloon,
14, 16.
non-compliant balloon. Dr. Han.
This is compliant balloon.
Compliant,
deflation,
deflation.
It's more easier to pass.
yes, compliant.
Great.
Yes. 2.5 high pressure balloon, please.
2.5. I think it's too small.
Yes, 2.5. I think so, but there are many lots of blood burden and calcification, so I like to do some step by step.
Proximal.
Usually my practice, yeah,
2.5.
yeah.
So one of difficult step is
Could you
to
measure-
introduce balloon catheter into the circumflex artery in this situation. So I think it's very good educational, some skill.
Can you measure the circumflex ostial vessel size? LAD 6,
LAD 6.
3.6. LAD 6, 3.2.
Okay. 10.
0.5, 10,
LAD depletion. 20.
20,
24.
20, 24.
Okay. What is the vessel size of a circumflex ostium?
Right.
What?
3.6.
Big.
3.5.
All right.
수치가 LAD 안에 있습니다.
LAD?
4.0
3.5 한 개 더 주세요.
하나 더 주세요.
Because the circumflex ostial vessel size is 3.5, so I like to the kissing bone dilatation for circumflex and LAD using the 3535.
Okay, great. So did you do the high pressure inflation distal part of the LAD?
No, I like to do first to correct the bifurcation, and I like to do
Okay.
the yes, I like to correct the distal LAD for, already. For distal LAD, I already correct.
What size do you apply? 2.5?
Yes, 2.5, 10.
35. Good.
Yeah. Deflation.
Inflation.
Circumflex 16,
16,
18,
16, 18,
20.
20.
Yes, no indentation, deflation.
그렇죠.
Did you do the distal,
LAD
distal
is
part of
3.5.
circumflex stand itself?
No,
Did you do that?
not yet,
Not yet.
not yet. So
Okay, just focus
yeah.
on the
10.
bifurcation.
10.
yes, 20,
20.
High pressure,
24,
sequence of high
28.
pressure,
4A.
circumflexion
28.
LAD low, and then
deflation. Yes, it is 26.
26, circumflex,
Yes,
26.
to achieve the sufficient minimum
26.
lumen area, we have to do the high pressure sequentially deflation. The role of final kissing balloon make the carina position in the right place. So we don't need to apply the high pressure.
all right.
It's just the 8A.
1, 2, 3.
4, 6, 8.
Yeah, I think it's good, looking good. 10, 10,
10, 10.
10.
deflation.
1, 2, 3.
No, wire. Keep the wire. It's okay. And depending on I was finding for the distal.
Because after high pressure, sometimes wire
You mean?
balloon
Balloon could not be pulled out. You mean? Great.
yeah.
Then do you usually choose the size of balloon based on the proximal LAD and proximal circumflex for the kissing balloon?
Yes,
is
right.
it? Yeah.
Yeah, not for kissing balloon, but for high pressure.
Yeah. But you already did the kissing balloon before.
But yeah, I was pleased. So yes,
Okay, Dr. Han. Can you hear me? We have enough time. The reason why next live demonstration, patient reviews, live transmission. So
okay.
take care.
Oh, thank you. Yeah, thank you. Give me the enough sufficient time.
All right.
So this is I was. If it is possible to passing through, but not to the distal. So let's see what happened the ostium of circumflex and ostium of LAD. Here is a very ostium of circumflex.
Great. Very circular.
Okay, very widely opening.
All right.
Yeah. Here is your left main. Yes, we did the final kissing balloon, so the left main looks not round but ovoid, but there is enough sufficient area for area, so I don't concern whether the shape is ovoid or round.
I think it would be perfect in terms of main crushing status, and so we'd like to know that the distal part, the small vessels are still, so underexpanded areas, and so we
3O. So before LAD evaluation, I like to apply the high pressure for distal circumflex.
3O.
What is the size of distal circumflex?
distal
Yes. More than far distal is 2.75, but above the far distal is 3.0. LAD 10. Okay. Deflation. Okay. 10. This is 3.0 high pressure balloon.
2.9.
10,
12.
12,
13, 14.
14.
Deflation.
Inflation.
20.
3.12.
So 20 is 3.1.
20.
Deflation. 22.
3.15.
22.
Deflation. 22.
3.15.
22.
Deflation. 22. 24.
24.
3.17.
Deflation. Okay, I'd like to see the IBUS. First for the diagonal branch, not circumflex.
great.
Frankly speaking, I spend more time after stent implantation because optimizing stenting is more important than just putting stent, I believe, based on the IBUS findings. Okay, here is there is some disease, but please. Some mild disease, but I implanted the stent distal edge on the very normal looking area. Look at, okay, here is another normal looking area. So here comes the distal edge stent. Distal edge landing is good, very round. Vessel size is less than 3 to 0.75. From here, I applied the high pressure using the 3.0 high pressure balloon. There is some tissue protrusion in the 12 o'clock, but the progressive meaning of mild tissue protrusion is not significant. Circumflex, even the circumflex, look at the circumflex vessel size is almost 3.5. And here I applied the 3.0 high pressure balloon, the up to 18 and almost 20. Final balloon size is 3.2 something. Even though the final balloon size is 3.2, in most cases, the final stent diameter is less than 3.2. So we have to check the IBUS after high pressure balloon. Very round, well opposed. SA, do you satisfy the minimal stent area in circumflex?
Yes, quite enough.
Yeah.
Actually, we made a cutoff value 5, 6, 7, 8 for the main bifurcation area, and recently Dr. Gang made another new cutoff value for the long-term outcomes, more than long-term, so at 5 years. Clinical relevance concern is bigger the better. 6 for the circumflex, 8 for the LAD, and maybe
LAD,
11,
11,
12
yes,
something is for the
left
left
main.
main. So I think it's quite enough. Is this left main?
Circumflex also. Yeah.
Circumflex
left main.
osteo.
All right.
Here, yeah.
Big enough.
Yes, here it, yes, here
Very
is
big
left
enough.
main.
This is main.
Yeah, yeah.
More than 12 something.
Okay.
Okay, great.
I removed the LAD balloon, so I like to show you the LAD IVUS findings.
A little bit concerned
Before
about
I was in,
the middle portion of LAD, the underexpanded area.
ready?
I think we have to fix up that.
Ready?
Great.
Cranial. Yeah, I am very satisfied with the proximal portion, but I also have a concern about the, you can see the stent a little bit underexpanded stent in the distal portion of LAD stent. So let's look at the IVUS.
Dr. Kim, in your lab, you use the IVUS frequently, right?
Yeah, that's right. Yeah.
How,
IVUS and
what percent of cases you use?
actually, for the left main case, I think more than 70%.
More than 70
yeah.
for all the
Almost, yeah,
cases,
yeah,
not
all cases.
limited, all the cases.
Yeah, that's right. But some cases there is some emergent situation. So that case we cannot use IVUS. Otherwise, we always use IVUS.
I think for elective cases, almost all of them, elective left mains where we have a OCT lab, so we are more compliant with OCT. But I think for all elective left mains, it's a must. For acute coronary syndromes, maybe you can leave it to individual judgment, depending on the patient presentation, the hemodynamics, a lot can vary. So there, of course, it's our individual judgment. But for elective left mains, I think it's a must for all cases. And Dr. Khan has shown very nicely, actually, how he's optimizing step by step, the MSA, particularly, that's what the whole beauty of IVUS lies in optimizing the stent.
20까지는 갈 수 있겠다, 거기. Okay, can you see some underexpanded area at the distal portion? I will review after finishing the IVUS fullback. Okay, here is the proximal part, the heavily calcified disease. But after breaking down the calcium using the high pressure balloon, and here I applied the high pressure using 3.5 high pressure balloon. Stent is well expanded. Continuous. 발음 좀 더 주실래요?
팔은요?
Okay, proximal portion, the very round shape and expansion looks good. Here is a very ostium of LAD. We made the new MSA criteria for crushing technique. MSA of LAD ostium was 8, definitely more than 8. Here is a POC, the complex coming from the 5 o'clock. Here is left main. Left main is huge. Okay, here is ostium of left main. Could you show us that the circumflex ostium minimal lumen area? Here is circumflex LAD ostium or circumflex ostium? Here is circumflex ostium.
네, 여기입니다.
Okay, could you show circumflex?
아니, 이거는 LAD.
circumflex ostium, could you show us and measure the circumflex ostium? Okay. Could you measure the minimal stent area?
Here, right, great.
Okay.
1, 2, 3, maybe more than 7, 9.
Oh, 9.
Big enough.
LAD ostium, could you show us? So this number is yes, simply this number I have a prognostic value, but this number included our effort to make a good stent result. So LAD is 9. Distal left main. Okay.
In fact, every cases we cannot make such as a big, stent
Yeah.
area, so just depending on vessel size, something like that. And
Yeah,
anyway,
right.
however, at the least, you made a new cutoff value. Remind us 6, 8, 11, 12, right?
6, 8, 11. Yeah, 11.
All right.
Yes.
So,
So
Dr. Han,
could you show us the
okay, what would you
Yeah.
do the next stage?
Okay, here, run please. Yeah, here is underexpanded distal, stent
right.
distal portion.
You want to make a 2.5?
I have a little bit, 2.5. So
2.5
I'd like to
non-compliant
apply the
balloon.
one more
Okay.
2.5.
All right.
Yeah, 2.5 or non-compliant balloon.
Okay. All right, Dr. Han. We're going to move to the next session. So from the New Life Severance Hospital.
Okay.
So would you show us in the later the final result, right?
Okay.
Thank you for your
Okay.
nice presentation, right?
Thank you.
Thank you, SJ.